actually introduce you, and maybe you can. Could you introduce yourself, Dr. Aimable?
Okay, thank you very much. I'm Dr. Aimable Ndayishimiye. I'm Rwandan by nationality, and I'm working in an NGO called Partners in Health. It has been funded by a famous doctor called Paul Farmer. It's an NGO that is focusing mainly on the care of the poor, generally those suffering from cancers and other life-threatening diseases like HIV, TB. It has been starting in Haiti, but now it has spread over the country in Rwanda and other countries of Africa. So we are dealing mainly with those patients who are suffering, who are having troubles with paying their health insurances, their care, healthcare services, and so forth. So I'm very happy to be here with you all. I'm very happy to be part of this program, helping those who need to know how they can manage pain. I didn't mention that I'm a national trainer on pain management, but so I am, and I'm very glad to be here because when you teach, you learn more than what you give. So thank you very much.
Yeah, thank you. So we're going to be starting our session soon, and we'll be having the teaching by Dr. Aimable. That will be about 20-25 minutes. And after that, we're going to be having a group discussion time. So this is a time where you can ask your questions, make your comments. And after we have this discussion time, we will be having a case presentation on the same topic, which is pain management, pain assessment and management. This will be by Annalice. She is a registered nurse who works in Kenya. She's worked with the International Rescue Committee for 10 years and is currently working in a refugee camp in Dadaab. And she is passionate about palliative care in limited resource areas. And so we are very excited to have these two speakers with us today. After the case study, we will have another small group discussion time. So as we are learning about ECHO, it really is a time for everybody to learn from everyone. So we welcome now Dr. Aimable and look forward to his presentation. And please, if you have questions during the presentation, please put them in the chat. We will try to get to all of your questions. If we don't get to all the questions during the session today, we will follow up. If you can leave your video on, that would be great, but make sure you mute your mic if you're not speaking. So, and put up your hand as well if you would like to speak later on when we have the discussion times. So we will just welcome Dr. Aimable to start his presentation. Thank you.
Okay, thank you very much. As you've been introducing, we're going to discuss about pain management, and we can't manage pain without having assessed it. So in this presentation, we'll be mainly focusing on pain assessment principles and pain management as well. So I would like to ask Ellen to help me with the sliding, so that we can go on. So, but before we start, I would like to ask everyone, is there anyone who have never get pain in any way? I want to hear from you. Just be free to talk. I don't think that, yes, I've got someone said I have had pain. Yes, that's it. Actually, we can't say that anyone has never had pain, because it's something that is current, that we meet in everyday life. I would love first, before going on, ask another questions. What do you understand when they say pain? What do you understand by pain? The word pain. Discomfort, hurts, uncomfortable. Yes, I've seen many people saying I've had pain several times, and that's good. It means that we can understand what is pain. Actually, I'm asking this because you can't treat pain without feeling what it is, what it feels like. And before we go on, there is something that is called the concept of total pain. We are going to see how we can assess pain, how we can manage pain, how we will be using opioids. But we need to understand those patients, those ones who are suffering, why are we helping them? Why do you have to help them? Why do you have to manage that pain? So that's all that I need to talk about. And I wish you can go on next slide, please. I want you to understand that pain doesn't mean that you'll be having only physical pain. When we be discussing about pain, please think that someone can have both physical pain, both psychological pain, both social pain, and even spiritual pain. That's why we are coming with palliative care, because palliative care and pain management doesn't go distant from each other. So we will be discussing about basic principles of pain assessment, pain management. I've said we'll be looking at different principles of, different tools that we may be using to assess pain, but as well we'll be seeing how we can manage pain pharmacologically and even non-pharmacologically using opioids or other medications that are used frequently to manage pain. So here you go. I asked the first time when I was introducing this course, why do you have to manage pain? Can anyone answer that? Why do you have to manage pain? When you don't manage pain, what can happen to the patient? To ensure the quality of life. Thank you very much. They don't want to eat, Helen. So we all know well that when we don't treat pain, everyone can get anxiety, can get depression, can get different complications, cannot comply with the medications that we're providing. That's why we need to see how can we help our patients, how can we help those sufferings with that pain. I like this one who say to make patient comfortable mentally and physically. I would love if you could add socially and even spiritually, because when you say the concept of total pain, we mean all of those things. And that's why we are going to study how we can assess that pain. Pain, as we've been saying since the beginning, is a complaint. You can't go there and say, I'm coming to treat you without having that complaint that someone is having pain. That's why we'll need to take the history. There are many options that we use to get the history regarding pain. I think some knows what you call PQRST. PQP means precipitating. There are many options. There are even some who use what we call Socrates to assess that pain. When you say Socrates, S means the site. Where is that pain? The patients come, oh, doctor, oh, where is he or she suffering from? What's the site? S, the site. O, onset. When did it start? Because this will help us to know, is this an acute pain? Is this a chronic pain? That's the onset. If it's an acute pain, you will know how you can manage it. If it's a chronic pain, you will try to rule out the cause behind that, that pain. And even the management, we will find later that it's a little bit different. And then the character. C, the character. How is that pain? Is it burning? Is it stabbing, like stabbing wound? How is it that pain? How do you feel like? How do you feel like? That's the character. Then the radiation. For those patients who have been having like stabbing for many days, they may suffer from what you call curling ulcers, which is stomachache. They may get hot from the stomach. Most of that pain may radiate to the back or to the shoulders. So you need to know, how will you differentiate that stomachache from the liver pain or from appendicitis or some other cause of pain which may be located in the upper belly or epigastrium, as we used to say, to call it. So that's why we have to know the radiation. So A, aggravating factors. Aggravating factors are those things that make the pain worse. Of course, when you say aggravating, we need to know even the relieving one. We can't ask what makes the pain worse without asking what makes the pain much better. That's aggravating factors. And then the timing. When is that pain severe or not severe? For patients or for people who are living in a closed area, let me call it that, closed area, you may find them very productive. Let me call it that way. They use to reproduce heavily. We may get many children. You may have a mother who is on the labor. So how will you know that that's the labor pain or what we call contractions or not contractions? You need to know, when is that pain coming or when is it going away? Then E, episodes. How many times? Is it colic? Is it coming and go like 3 times a day or 4 times a day? And then, of course, severity. Severity is what we'll be assessing soon. We have to know that pain. Is it mild? Is it moderate? Is it severe? That one will help us to know which medications does that patient need to get. And then let's suppose that we are done with history. It doesn't mean that you need to ask only the classes. You need to ask as well everything that may be related from the family, from background, any chronic disease, any past medical history, and each and everything. That's history. And then, as we know well, after having the history, we need to examine. There are what I may call like form principles of examinations. We always need to look, what am I looking? The patient is saying that he's having pain. So how is it that? Is she or he having a wound? Is he or she having something which is hurting her? So we need to see the inspection. After inspecting, then we touch. You have to palpate either lightly, smoothly, either medium or even deep. But for the site where it is hurting much, you need to go slowly and don't hurt the patient, because we need to relieve pain. We don't need to provoke more pain. After that, after palpation, when it's possible, we need to PallCHASE. Suppose that we are having a patient who is having an acute abdomen. We are having adult people who may be having strangulations, or why not an appendicitis? Why not bowel obstruction? She's complaining of abdominal distension and even abdominal pain. So how will you know that it's water which is inside? How will you differentiate bowel obstruction from ascites? You need to PallCHASE. You need to feel the dullness or the tenderness of that abdomen, so that you may differentiate what's going on with the patient, that examination. And after percussion, you need to auscultate. Here we are having a young, I don't know if it's a young lady, a young doctor who is auscultating the man who is sitting. Yes, that's an examination. He's doing auscultation to see what's wrong with the lungs. So after examination, of course, we need to investigate, do some needed examinations to know what's going on. Next slide, please. Probably I need to be quick because I'm having too much stuff. So during assessment, of course, there are questions that we need to ask, and you'll find that these questions are almost similar to what we've been saying on the Socrates. So what is that pain? What it is? How do you feel it like? So when is the onset? Timing, I've said. Treatment, if you have ever experienced other medications before. So what do you think is the cause of that pain? And of course, how is it changing? I've been saying aggravating or relieving. And what do you think is locating that pain? Next slide. These questions can summarize the Socrates or the questions that you need to ask. So then we are here for assessing. On the last S of mine, in Socrates, I mentioned the pain severity. To assess pain, we need to know which patients am I examining? How old is she or he? So what is the most suitable? For example, we may be having a numerical rating scale. If I don't know how to count, I don't know what is 1 or 2, what is bigger than 5, that between 4 and 5. So it's not good to use numerical rating scale, but you may use verbal pain intensity scale, where we'll be mentioning, are you having pain? Are you having no pain? So when you say no pain, it means that you have 0. When you have the worst pain, it's 10. So there you may ask the patient, where can you classify yourself? Is it no pain? Is it worst pain? Is it a small pain? Is it a medium pain? Is it a severe pain? These are for adults. The numbers are for those who can give you the right answer on the pain severity. So for children, how are we going to assess children? They usually say that children who are more than 3 years, you can use what we call Wong-Becker FACES scale. This one we have is FACES scale, but we shall see if you can Google it, you can find what is called Wong-Becker FACES scale. For that scale, we'll be having even some children who are crying. So what you do here, you explain to the children. It means that you use it for children who can provide you the the reality regarding he or her pain. The first one, he's happy. The first one is looking at you fully, just confidently. He doesn't have pain. The second one, start to be angry. He's having very mild pain. The third, things have changed. The pain starts to become moderate. The fourth, the pain is severe. The fifth, the pain is very severe. Even she can't even look at you. She has even wrinkles. He's having severe pain, very severe pain. And the last one, he's experiencing the worst and the worst of pain possible. That's why for the Wong Baker, you may find that patient crying, crying, and crying. So this is how you will be examining the children. Remember that these children, they're most likely to feel like what you're saying. You need to express and show her or him the love so that it may explain you or give you what you really want to get. You need to build that confidence in that patient, in that kid. So this is for the simple way that you can use to get the scale. You may say, oh, I did say this. Go on. So for children less than 3 years, how are we going to assess them? We didn't get deeper than in these presentations, but we may see what we call behavioral rating scales where we are dealing with the patient's behavior. For example, there's patients who are less than 3 years, who can tell you I'm having pain, who can tell you I'm having this severe pain. That's one example. Patients who are intubated, who are very sick, they can't tell you, okay, you see, I'm intubated, I want to tell you that I'm having severe pain. No, he will never tell you that. You just see how is he or she behaving. Are we together? So for children, we have this rating scale called FLAC scale. We assess it as well as we assess the APGAL score. I think most of us know what is APGAL. So APGAL is the same as this. We look at the appearance. Here we look at the face. If there is no particular expression, or when the kid is smiling, okay, that is 0. There's no pain. When the patient looks worried or sad, that's something else. He or she starts to experience some pain. That's 1. When the people look distressed, he's panicked. There's something else. Then it's 2. There is some pain greater than what she was having on 1. So we assess everything on this form. You don't have to memorize all the whole table. You just need to have this chart so that you may, if you meet a child, you may try to relate what he or she is showing you with what is already there. That's how we assess FLAC scale. You will find somewhere saying that FLAC scale can be used for children 4 to 7 years. Don't be astonished by that. It's okay. So let's come back on pain management principles. Actually, we are having almost 4 principles. 4 principles. The first one, you need to take medications by clock. It means if the doctor or if the healthcare provider tells you, please take this paracetamol every 6 hours or every 8 hours, it means that you need to obey that. This helps us to manage or to control that pain. If you don't, you may experience some other episodes of pain which are not good to get. The second one, even though it's not mentioned here, but it's almost similar to the first, you have to take these medications regularly. You need to take these medications regularly as it has been prescribed. The third is by month. Why do you choose by month? If I'm injecting you morphine, aren't I causing that pain as well? Because I'm injecting you, I'm hurting you. Even though I'm trying to give you medications, but I'm hurting you. That's why we prefer by month, because you get it through month and there's no pain. The fourth is by ladder. Ladder goes hand in hand with the pain score. WHO analysis pain ladder has 3 main steps. We usually say that step 1 is for mild pain. If it's mild pain, then how are we going to treat it? We are using paracetamol or non-steroidal inflammatory drugs. Example, ibuprofen, diclofenac, and so forth. Most of the time, we may even find them combined. By now, we are having some combined medications containing paracetamol and non-steroidal inflammatory drugs. But to use them, we need to be specific. We need to know what we are doing and to which patients we are providing these medications. We shall see in the upcoming slides where can't we use paracetamol, where can't we use ibuprofen. So there is what we have added, that for step 1, you may add adjuvant. Anyone knows what is adjuvant?
Dr. Aimable, we are left with the 3 or 2 minutes.
Let me be quick. Thank you. Okay. So, good. I was saying that step 1, you can use paracetamol and ibuprofen. Step 2, we can use tramadol or other weak opioids. Unfortunately, I was having too much time, but as we are having a few minutes, I'll be trying to be quick. So for tramadol, what I can say is that it's better to do not use it in children below. We are having both immediate and sustainable release, but the best way to use in acute pain is morphine with immediate release. So we are having adult dose, starting dose is 5 to 10 milligrams every 4 hours. But for tonight, it's better to know how we'll be managing that pain. That's why we give a double dose at 11 p.m. so that we may not need to give it for the next hours to come. So for child, better to use 0.3, the starting dose. And instead of giving tramadol, please give morphine for the young patients. So why do we say opioids? Opioids has been put among the essential medications that we are having that we can use to treat pain. Here it's well mentioned from 1977 and so forth. We go on. So opioids, we take them, but we may have some side effects. Whenever we are prescribing opioids, please go on. Remember that there are some side effects that can come. So here, we may be having what you call weak opioids and strong opioids. I have mentioned it before, and I think anyone here can explain what is weak opioids, where can it be used, and strong opioid, where can it be used. I have seen that in Lesotho, probably may not be having, there's oromorphine, mainly the syrup, but it's a good thing that we are using here in Rwanda, mainly for cancer patients. Do you know well that they get severe pain, very severe pain, so we are using morphine syrup. I think working with ECO, I think we shall think on it so that we can keep helping these patients. Thank you very much for saying that. So let's go on. I was saying that we can have some side effects. Among them, please, whenever you're prescribing morphine, remember that it can cause constipation. That's why we encourage you, whenever you prescribe morphine, give as well Laxena. They can cause nausea or vomiting, can cause drowsiness. Another thing, I have seen that many nurses get scared of providing the prescribed morphine.
Registration doesn't guarantee.
Sometimes it can cause a kind of sedation after providing it, because the patient was in severe pain and she's relieved from that pain. Most of the time, you may find him or she slept. Don't think that it's respiratory depression, as we used to say. Most of the time, respiratory depression comes when you use overdose. So please don't get scared of providing morphine for those who are having very severe pain. So because the time has run away, I think I don't know if I can keep on talking, but you can take provide another slide, please. But when it comes to pain management, please remember that apart from these medications, everyone can get some other issues. So treat pain, considering that apart from physical pain, there may be some other types of pain, other causes of that pain, including psychological pain, including social pain, including spiritual pain. So by using them, you can get other things like addiction or tolerance. But I think you shall go through those slides. Please keep on going. So what you need to know so far, for old people, don't give the dose as those of the young one. Those who are having, because most of these elderly people, they may be having slow metabolism. So the medications may stay longer and it can cause easily the side effects, upgrade the side effects. Those patients who are having renal impairment or hepatic impairment, there will be some problems with clearing this medication from the body. They may stay there for long, and if you give another dosage, it can make worse the side effects. For pregnant and lactating mothers, they say that it can pass through the placenta barrier. So when you provide opioids, it can cause the side effects to the young patient who is in the womb. I mean the fetus. So please avoid to give pregnant mothers and lactating mothers opioids. Another thing, for patients who may be taking some medications like serotonin reuptake inhibitors or anti-epileptic medications, please don't give tramadol, because when the threshold is low, is high due to those medications that may enhance the risk of epilepsy, tramadol may worsen it and make that symptoms very worse. So I would like to thank you. As we will be keeping in touch, we shall keep on discussing on different things of pain management, but we need at least to remove those false beliefs about morphine. They say, for those patients who are in their last days of life, do you have to stop morphine? No, we don't, because that patient, even though she's in the end of life care, she needs to die in a peaceful way without having that pain. So another thing, morphine hastens death. Nowhere. Palliative care cannot prolong life, I mean. And morphine doesn't, it improves the quality of life instead of hastening the death. Myth about morphine again, it causes addiction. Patients who have pain do not become addicted to morphine. That's why they say that there is no upper dose of morphine. Whenever the patient is feeling pain, please add 25 to 50% of the dose he was having so that you may relieve that pain. So.
Thank you, Dr. Aimable. I think we're going to have to cut you off. I'm so sorry. Oh, it looks like
okay,
you're.
So thank you very much.
We
yes,
just want
thank
to
you very much.
We just want to make sure we have a little bit of time for questions. So now would be the time, and maybe, yeah, you will be able to share some of the stuff through questions. So does anybody have a question? You can raise your hand, or you can just type it in the chat.
Yes, sure.
I'm just curious. I was watching the chat, and it looks like they don't have a problem with access to morphine in Lesotho. So one of my questions, I guess, maybe you can't answer this, but maybe somebody else is it common for people who are palliative in Lesotho to receive morphine? Is it a common thing?
Dr. Hassan might be able to answer. He is leading most of the clinical work there.
Okay.
Okay, thanks. Okay, hi, Esther, what's the question about morphine? You said, is it available, but I didn't get you properly. Can I please?
No, my question is, it looks like from the chat it's available, but are people using it?
Yeah, okay. So currently we have morphine syrup and morphine tablet in the Sankatan Oncology Clinic Pharmacy, supported by Ministry of Health. I think that's the answer I can give you. Like for cancer patients, yes, it is available, 100% available. Yes.
That's good.
Thank you.
I think
Can
some
I
of
just
the realities. Oh yeah, Tabello obviously can also share, but I think some of the realities in Lesotho is that not all patients can access cancer treatment because of where they live, and also because of their lack of awareness of what symptoms are and when to come. So it is really great that the center has access to morphine, and we can continue to advocate for patients to get to the center. But I think there are a lot of barriers for your average person from Lesotho. And therefore, I assume there's still a lot of people that have untreated pain.
Well, I want to comment on that last statement, please. Yeah. So actually, the patients were diagnosed with cancer, who is referred from different corners of the country to Sankatan Oncology Clinic. 100% of the patients have access for pain management, and if they need morphine, yes, they have the access to morphine. Thank you very much.
Actually, I was having one more question. Apart from morphine, what other opioids are you used for the patient with pain?
Okay, is it the doctor who presented, right? Thanks, doctor, for the good question, and thank you for your nice presentation, though we could not have it fully because of time. Okay, so we have access to tramadol. We have oral morphine. We have syrup morphine in Sankatana Oncology Clinic Pharmacy. Yes, that's the answer. Yeah.
Okay, great.
We have a hand raised by Situngone Lucia.
Okay, thank you very much. I think this one comes from the experience that okay, I will always refer to my mom. She had a very excruciating pain. Anyway, she didn't have cancer, but she had a heart problem. So you could see that she is in pain, but I'm not sure why she didn't really access morphine. Instead, she was always given Panado and Tramadol, of course. But I still feel like the pain was really more severe than those. Hence why I feel like it's more reserved, and perhaps that could also be looked into. Thank you.
Thank you.
Yeah. Can I add something, Esther, please?
Sure.
Yes, I do very much acknowledge the remarks from Dr. Hassan, and his team are working hard to make sure that our patients have adequate pain management at Sankatana Oncology Clinic. But I also share the experience of Situngwane not having access to morphine. And as a country, I think that we get to acknowledge that even though we have made these major strides by having Sankatana clinic and being able to give medication to those cancer patients that come through their doors, having been assessed to have severe pain. But the issue is still a countrywide issue, whereby somebody who is in a far hard to reach a district like Mokoto or or anywhere far, they don't even have that money to travel to Hassan and his team. So we need the adequate availability of morphine, not just being adequate in the pharmacy cupboard, but being accessible for the patients to have in every district, in every clinic. And we just need to strengthen the guidelines, the policies, all the logistics that would be of concern in terms of safety and storage and all that, because the people are not having adequate access to morphine. We have got so many cancer patients that are getting hold of us as Starlight Oasis of Hope Hospice. They go to the clinics and they get only paracetamol, like Melushi has just shared her own experience. And the highest they can get most times is Tramadol, which in my own experience, having had my sister-in-law who had issues that demanded a stronger painkiller, she used to get only 6 patients, but to come back after 8 weeks, which was only covering 2 days. So we need more access and more availability of stronger painkillers. Thank you.
Thank you.
May I please raise my hand for Esther? Can I just comment on my brother from Rwanda's presentation? One comment, please, and that then. If
sure, we're going to take your comment, and then we're going to move to the case. But we can have more discussion during the case.
Yeah, just one comment is on the the brother from Rwanda. Thanks, a very nice presentation. I'm telling again, one comment, she has nicely presented that the oral by mouth, the reason not injectable by mouth, actually the reason is that the opiates are better absorbed in buccal mucosa than any other route. That's the reason it is always inspired in palliative care to use the opiates in through the oral route. Thank you very much.
Thank you. Thank you, Dr. Hassan. So we're going to just move on to the case presentation by Annalice, because we'll be getting more of the same kind of discussion during that. So Annalice, are you able to share your screen and start your presentation?
I think Tabella will share again, if it's possible.
Okay.
Yeah, let me find it. Sorry.
Annalice.
Tabella, before you go on, actually, I want to share a very small experience regarding the control of morphine and other opioids. here in Rwanda, we've been having that issue as well, where medications like opioids were kept in cupboards for so long. But by increasing the awareness of the importance of these medications to the non-physician clinicians, I mean nurses, midwives, and other healthcare providers, by doing presentation on pain management and opioid management, it has increased the number of those who can control those medications. Of course, they are very important, but they need to be controlled as well. So I think what is needed there is to advocate, of course, but try to increase the number of healthcare providers who are trained on opioid management. I think it can help very much. Thank you.
Thank you. There is a question, Dr. Aimable, in the chat. I'm just trying to find it about a specific medication. And I'm wondering if you could answer that question in the chat. And it was, but is there a medication called pethidine or something? Paridine?
I think it's pethidine, but yeah, maybe Dr. Aimable, you can reply in the chat.
If you could reply in the chat, and then we can start with the case. Thank you. And there's another one in the chat about another medication. If Dr. Aimable, would you mind just reading and responding in the chat? And then, sorry, Annalice, you can start your presentation.
Thank you. I don't need to introduce myself again, already introduced. I'm glad to be here. I'm presenting a case on pain management. Next, Tabelio. The case is about a 35-year-old man, inpatient, with the forgetting head and neck cancer, oncological treatment not available, presented with the very advanced stage disease. The main issue was severe pain preventing sleep. Next. Pain continuous over large area of face. That is the ears wounds of the face. The pain was rated at 9 out of 10 in severity. Pain worsens at night, preventing sleep, and at a time of dressing. And when they are changing the dressing, then some relief with the morphine immediate release, 10 milligram per oral. That is PRN, given prior to the dressing change. Pain score reduced to 7 out of 10, which is also minimal. Then other symptoms were reduced appetite, low mood, poor sleep, malodor from the wound, bleeding during dressing, itching at the wound site. Then social and spiritual presentation of the patient. The patient is married with 5 children. Father is the one giving care of the patient. Long stay as inpatient. Is a Muslim by faith. Important to him. The pain management was, I will wish that all the participants respond to this question. Just 1 minute in the chat, please, or if you can talk. How can we manage this man's pain? Which medication and at which dose should we give? Let's look at the slide. Ntebelio, you have taken us back to give us the answer.
I think we need to ask about his pain. What more questions about his pain? I know you gave some.
Mhm.
Have they tried anything?
Uh-huh. I think Dr. Aimable has given us the answer here. So you shall be giving morphine of immediate release, 10 milligram every 4 hours, or PRN, the maximum hourly, and then before dressing, once daily. Then regular vascodile to reduce the abdominal discomfort and constipation. We give pain reduce 6 to 10, and then sleep improved. Then what is the next step for pain management? I can't be able to see the chart. Please, Erin, if you can see the chart, if you
Yeah,
can
there's
share something.
Lots of really good comments. Morphine, 10 milligrams for hourly, which is really good. Also, the idea to do breakthrough doses, which is really important. We may not get a chance to teach on that too much today, but that is really helpful to know if you are prescribing morphine. We do need, it talks a bit more about psychological assessment is really important, and we need to make sure we're supporting the spiritual and social needs of the patient as a next step. Connect with the patient's imam or faith community. Continue with morphine. I think that's really important too. That's a really good comment. If we give a few days of morphine, this person's pain may not go away, right? Because we know the cause of the pain is an illness, advanced cancer. So adjuvant meds could be used, continuing to assess the patient's level of pain and increase the pain medication if the pain increases. Dr. Hassan suggested a G-tube insertion for feeding. So we do need to think about the patient's nutrition. I think that's good. Anybody have a thought on the laxative? I know it was said here, but is that a common prescription? Tabella, if you go back for 1 minute, is that a bisoconazole?
Vascodile.
Yeah, is that something that you guys use in Lesotho? If you just want to say yes, if you use it, or no.
No. Most cases, no.
What do you have in Lesotho for constipation?
Lactulose and Maxilon. Again, maybe liquid paraffin. So of course, during our echo trainings, we try to teach best practice. And of course, what you have access to, you do need to be using what you have access to. And I think that's the advocacy piece that we were talking about earlier. So as you come along with us over these next several weeks, as we teach about new topics or we bring in new ideas of how to assess and treat certain symptoms, you may learn something new, it may be a refresher, but yeah, we definitely want to find ways to support you where you are working. Looks like Maxilon is the most common one. Yeah, go ahead.
So there was increased dose of morphine, and then before dressing also the dose was increased and pain controlled. Morphine changed to 60 milligrams sustained release tablets every 12 hours, and then morphine 20 milligram immediate release PRN, 20 milligram at dressing change.
Annalice, if I may.
Yes, please.
Actually, when we say the pain is controlled, it doesn't mean that the pain is zero. So for this patient, we have seen that we have given morphine, immediate release, 10 milligram every 4 hours, but still there were some severe pain. When you say 6 out of 10, it is still severe pain. So by giving 20, probably when they say pain is controlled, it doesn't mean that he or she's now having 0. It may be having, she may be having 2, it may be 1, but at least that what we call the quality of life now is restored. She may feel better. That's why we say the pain is controlled. Don't keep in mind that when we say the pain is controlled means that the pain is 0. No, it may be 2, it may be 1, but at least the patient is feeling much better, is having the quality of life back. It's what it means. Thank you.
Thank you. I think that's an important comment to make, because sometimes people feel like they should, the pain should be 0. And I think it's important to not give false hopes to patients, that we're looking at quality of life. And like Aaron said, pain is subjective, so it's different for different people.
Thank you.
Sorry, Annalice.
Anna, it's okay, it's learning. Next, Kevin. So the management of other issues was also improved by itching. We was given chloramphenicol, that is Piriton, at night. Then it also helps to improve sleep and control some pain and distressing symptom mode, counseling, and then some improvement with pain control. Once the pain has gone down, the quality of life improved, mood also changes, and mental health support was provided. Maladol crushed metronidazole tablets applied to the wound after cleaning with normal saline, then bleeding, tranexamic acid applied to gauze, and pressure applied to the wound site, then bleeding stops. Next. Question that we need to discuss about: how to select an appropriate pain medication and develop an appropriate pain management plan. What is the starting dose of morphine? How is it titrated? What are the side effects of morphine? How can they be prevented or managed?
Are we all back in the main room now?
I think so, yep.
Yes, sure.
Okay, so I hope everyone had some good discussions in their chats. It was interesting in our group. I think we're having Joan is going to share something about pediatric. Joan Martin, are you back in our big group?
Yes, I am. Thank you. I'm just going to very briefly talk about it, because you're going to have a session on pediatric palliative care, and I'm very sure that Julia will cover these when she does the presentation. But just to say, there are a variety of tools that we can use with children. We have a neonatal tool, which is called NIPS, and that's a very easy tool to use. Then we have the FLAC scale that we will use with young children until they become verbal and have some understanding on the levels of pain that they're experiencing. So I'm always very loath to use age groups too strictly, because it depends very much on the individual child. The FLAC is also very good for non-verbal children who are older. But it is a tool that you have to take time when you use it. It's not something you quickly look at the face and the legs and the activity. It is one that you've got to spend a bit of time looking at the whole body as well. And then when we come to the numerical scales, and I include the faces in that as well, because you're asking if you're asking a young child to differentiate between 1 and 10, a level of pain, it can often be very difficult. And I find often with children, we use a simple hand. And we might say that when my thumb is down, I've got no pain, and then just use the 4 fingers going up from the smallest finger to the 4th finger. I wouldn't use the Baker-Wong scale. You know, some years ago, we found that children were looking at that scale and really choosing the face that they liked the best. And that's when the revised faces scale came in. And again, it goes 1 to 10, which I'm not crazy about, but it depends on the child. And before you use any of the scale where a child has got to tell you where their pain is, you must make sure that they understand how 1 might be just a tiny little, they might have hit their finger on a board, where 10 would be the worst pain they could possibly imagine. So that child's got to understand that pain is a gradient. It goes from very little, it can go up to a lot as well. So until the child understands that, then I wouldn't use that. I wouldn't use a 1 to 10. I'd use a very simple 1 to 5 scale, and I would use the revised faces because this has been tested and it's also WHO recommended. But I do know that, having worked in many countries in Africa, that people love the original faces scale. I've seen badges, I've seen bracelets, pictures on the wall. So the best thing to do when you're doing pain assessment in children, use the scales that you feel comfortable with, and use the scales when a child has got to explain what their pain is, that child understands and can explain to you. Let them explain back to you what it would mean if they had a pain that was a 2 or a 4 or a 5. And when they can explain that to you, then you know that you can use any kind of scale that has some kind of numbers in it. I also quite like the Elan body tool, which is simple pictures of boy and girl back and front. And the child they can show you on that tool where the pain is on their body as well. So pain assessment in children can be quite complex with your children who are very non-responsive. I think of those children who perhaps have had some kind of brain trauma, TB meningitis, and where they already might be, have a lot of spasticity of their muscles. So sometimes you have to use a lot of common sense. And always with children, if something is going to hurt you, it's going to hurt the child. So it's really using all the knowledge you have and taking it to that little child that you're caring for. But I always say you must use a tool, because how do you know that you're improving your pain management? And the last thing is, I was on the WHO guidelines group that looked at codeine. And we don't like using codeine with children, because of the uncertain metabolism. And there have been deaths reported in children who've had codeine. So we say codeine is a no-no, unless you have nothing else. That's always the other thing in a country where that might be the only medication they have. Then you use it with carefulness. Yeah.
Thanks, Joan. We've got George and Tabella. George, would you like to make a comment?
Yes, thank you very much. Thanks, Joan. I agree absolutely with everything you said. I'd just like you to know what your experience of using, comparing what a child indicates is their degree of pain and a carer or their parent, because I've worked in situations where child is being very brave and the mother or the carer is saying, no, the pain is much worse, he's being too brave, he wants to please you by saying he's, have you got experience? Would you like to say something about that?
Yes, I have. And I find that usually, in fact, the parents have underestimated the pain. When you ask the parent about the pain, oh, it's not bad, it's much better. And then when you take the child separately from the parent, and that's when I separate the two. put the parent, tell the parent to go and have a cup of tea or something and sit with the child, because in a lot of our children, it's very cultural. The parent speaks for the child. And so as long as the parent or the grandmother, often it is the grandmother or an older sibling is with the child, they will just go along. So if I have a child who can explain their pain, then I separate the two.
Interesting. Thank you for that. Thank you.
I listen to what the child says, and I take it as the child's estimation of their pain.
Thanks. And Tebello, did you have something you wanted to add?
Honestly, I think my statement is just a great appeal for my colleagues and my seniors and professionals who are on the call. I just want us to be honest with ourselves. The trainings are to address the care gap that exists. Undeniably, we know. And we just need to acknowledge that we have got an issue as a country in terms of pain management. We need to acknowledge that we only have one clinic in the whole country of 10 districts. And we have got so many hard to reach districts and villages out there. And most of the cancer patients are in the rural areas. Because Lesotho is still not very strong on the research aspect, we haven't got the real evidence to actually really put a case that in the rural areas, that's where the prevalence of cancers are. But that is the case anecdotally, as I remember from the practice. Now, the challenge is if the clinic is in Maseru and the far hard to reach district in Mokhotlong or Kacha, the patient is around that area and there's no morphine in the pharmacy, how are they going to access it in Maseru? So these are the things that we need to leave this lecture or discussion, knowing that we have got every little bit of contribution to make a difference in the patients we look after. And we have to have an honest discussion that is not battering anybody's service or practice. It's about coming up with an honest truth in our generation and age that we need to address these gaps. If I am in the similar situation at some point, which I pray should not be the case, I would not want to be given 2 paracetamol that will not address my pain if I need the pain relief. And I have had my own patients very dear to me, which I knew I had to go out of my way to communicate with their patients in Bloemfontein so that they can prescribe more doses that will cover them for the next appointment, because there was no way they would get anything in the country. So please, we have got our doctors on board, we have got our nurses, we have got our pharmacists. Some of them are very senior in their roles. Honestly, we need to have something to discuss and address these issues with the guidelines, with advocacy, and with availability, not just availability, but with accessibility, because people are suffering and there's no need for that.
Thank you. Thank you.
Thank you.
You're very passionate. Thank you very much. And Dr. Aimable, just wondering if you had a few words that you want to add at the end.
Oh, thank you very much. First of all, I would like to say thank you for giving me this opportunity. What I may just recall to everyone is that pain management is not something that is done one day and then say it's done. It's a continuous process. It's a holistic approach. It's something that we need to always think on, especially for those patients who are suffering, mainly cancer patients, but not only cancer patients, but also we have to remember those mothers who are on labor. They experience that much pain, and most of the time, due to culture, different cultures, we may say, oh, we need to get pain to get the child. So we need to think not only on medications, but also be back on a pharmacological way of helping those patients so that we may approach them in a holistic way and providing the effective and appropriate pain management. So thank you very much.
Thank you. And thank you to everybody. I think that was very well said. I think pain management is something that we're always learning. The ways that the different pains get managed, often they change. I know in Canada right now, they're using a lot more methadone than they're starting to move away from morphine. So I feel like there's always something we can learn. And also every person is different. And so how they experience pain is going to be different. And this is one thing that came up in my group. There were some people who are not healthcare providers, and they were feeling like they don't really have, it's difficult if you're not going through pain. They need a lot of support, and their families as well. And also I wanted to just appreciate Joan, your what you said about pediatrics. I feel like adults need the same thing. My patients don't love being asked what their pain is on a scale of 1 to 10. They get very tired of that. So I usually just go, you know, is it like this? Is it like this? Is it like this? What is it stopping you from doing? You know, can you get out of bed and go to the bathroom? Can you sleep at night? People get really, really tired of having the same question. But the other thing that you said, which I think is very important, is that we communicate in a clear way with our team, so that we aren't asking the same question all the time, but so that we are truly all sharing the same thing, because it can be confusing if different people tell you different things about why you have your pain and what you need. So thank you very much to everybody for a great session. And we will be sharing more information in the WhatsApp group. So you will have different ways to access this. I'm not sure if anybody close to the end, does anybody have something burning that they wanted to share before we say goodbye? So next week we have another course, and I believe that next week is going to be on symptom management for patients with advanced disease. And I think there may be some end of life care as well. So we look forward to seeing everybody again. It's a great turnout. Thank you so much to our presenters and to everybody who participated. And I guess I'll just, Erin, is it okay for us to end the meeting?
Yeah, I'm just going to share a feedback link. I always forget the feedback link.
I forgot about that.
Let me quickly share it. And yeah, have a great night, everyone. See you next week.
So just that everybody gives some feedback. Don't forget to follow the link. That gives us an idea of how things are going. Sorry about that.
Thank you, everyone.
Bye.
Bye-bye.
Bye.
Thank you. Bye.
Bye.
Thank you. Bye. Bye.
Bye all. Good night.
Bye, Annalice.
Good night.
Bye.
Good day in America.
Thank you.
Oh, man.
Bye.
I'll have to share it.